Good afternoon to all of you. I have made a slight change in the topics. I thought of starting with eczema or dermatitis rather than the vesicular diseases. Because, with this lecture, we will be talking some aspects of the dermatitis. Dermatitis is a very common condition where we see a lot of patients in our dermatology practice. So eczema and dermatitis is shared in a common meaning. It's defined as a clinical and histological pattern of inflammation of the skin seen in a variety of dermatoses with widely diverse etiologies. So it is inflammation of the skin, dermatitis. Like in appendicitis or pneumonitis, you get dermatitis. It's inflammation of skin. So in general term, it is called as eczema, but sometimes in the medical literature also we use the word eczema, and also dermatitis. Eczema is it can occur in about 10% of people at some time of their life. So it's so common, and up to 40% of the population will have an episode of eczema during their lifetime. 10% have at any time, and 40% will have during their lifetime. So it's a common problem. In dermatology, actually, different types of eczema constitute a majority of patients. So in common, in dermatitis, you get these features. So in eczema, you get these features. Sorry for the interruption. There is dryness, itching, and soreness. So these are common features for the eczema, whatever the etiology is. So it may be atopy or contact dermatitis. The initial features would be dryness, itching, and soreness. So when the inflammation goes on, you get erythema due to the blood vessel dilatation, then mild cutaneous edema because of the capillary dilatation. There is fluid leakage to the dermis, and excoriation as a result of scratching, and then they can become papules. Then there may be scales due to the overactivity of the epidermal turnover, and there will be vesicles due to the fluid leakage into the epidermal cells. And then you get the exudate, then it becomes chronic, becomes fissures, hyperkeratosis, and lichenification. So lichenification is the chronic form of dermatitis or eczema with pigmentation, thickening, and exaggerated skin lines. So those are the three features we see in lichenification or lichenified eczemas. It is pigmentation, increased pigmentation, thickening of the skin, and exaggerated lines. So lichenification and lichenified eczema will be, you will meet those words. So understand that those are the three features which occur in lichenification. So when we look at the histological sides, you can see there is acanthosis or thickening of the epidermis. So here you can see epidermis is thickened, and hyperkeratosis. So we call hyperkeratosis when there is thickening of the stratum corneum. I hope you know about the layers. Stratum corneum is the outermost layer of the epidermis. When there is thickening, we call it hyperkeratosis. So you can see in the stratum corneum, there are nucleated cells as well, in addition to the thickening of the epidermis. And here you can see the keratinocytes are a little bit edematous, and you can see the well-demarcated cell margins. So cells are separated well due to the edema of the epidermis. And in the dermis, you can see lymphocytes infiltrating in the perivascular manner, and there is lymphocytic infiltrate in the dermis. Then if we look at a closer view, there is separation of the epidermal cells. Now, there is a lot of fluid leakage due to the capillary dilatation that will, including the inflammatory reaction, these keratinocytes will get separated each other. So you can histologically see these cavities, and when it is severe, you can see a tiny vesicle being formed in the epidermis. So in acute eczemas, you will see vesicles. So in any dermatitis in the acute stage, these vesicles will be seen. That is how they are formed. Gradually, they will break off from the top and discharge the serous fluid. When we look at the eczemas, how to classify? So there are different types of eczemas with different etiological factors. It is commonly classified into endogenous and exogenous types. So in endogenous ones, you don't get an obvious external factor. In exogenous one, you get some obvious external factors. So that is the basic classification. Under endogenous, the major area is atopic eczema. We will be talking in details. Atopic eczema, discoid eczema, hand eczema, seborrheic eczema or seborrheic dermatitis, venous or gravitational, then asterotic eczema. So the latter ones we will see some pictures, and the top ones we will be talking in details. And contact eczema can be irritant or allergic. So contact eczema is due to an exogenous factor where you get some chemicals touching the skin. So now you can see that contact eczema or contact dermatitis has two main branches. So they are not same. So contact eczema can be irritant contact dermatitis or allergic contact dermatitis. Irritant contact dermatitis is due to the irritating qualities of the substance which we are in contact, will give rise to a dermatitis. The allergic contact dermatitis, there will be an allergic reaction, that is your immune system will be overactive, exposed. Then photosensitive eczema or photodermatitis, sometimes there are certain dermatitis exacerbated by photosensitive ultraviolet exposure. So that is another exogenous eczema, and lichen simplex or nodular prurigo. So these are where people scratch due to some reason and then the skin becomes lichenified. You can remember I explained it a few minutes back, and so that it will lead to certain skin changes. So let's see what happens as the pathogenesis. So we saw the pathology or the histological changes. Pathogenesis. So it will be an interaction of trigger factors, keratinocytes, and immune cells, T lymphocytes. So those will be the interaction of these factors. So it can be an immune reaction to small molecules, haptens. Haptens are ones which join certain proteins in the body and give a reaction. Then Langerhans cells and dermal dendritic cells are the ones who travel in the epidermis and look for antigens and detect them. So when there is some substance in the epidermis or the dermis, this will be caught by these Langerhans cells, and it will be carried to the regional lymph nodes, and that will be encountered by the new T cells, which are not programmed for any specific function. So this stimulation will give rise to differentiation into a variety of subtypes to these naive T cells. So they will be secreting different cytokine patterns. So we commonly known ones are Th1 group and Th2, but there are other T helper cell groups, sometimes Th17, Th22, etc. So those cell lines will be differentiated with the stimulation. Then there will be certain T lymphocytes with regulatory functions to modulate allergic contact dermatitis. So these T cells will migrate to the site of the damage. Then that is when they travel through the blood vessels, and endothelium will express certain receptors where there is damage. To those receptors, these T cells will get attached to the endothelium and then creep into the dermis and epidermis. So there will be epidermal damage, spongiosis. Spongiosis is the change which we saw in the histological slides. And T-cell mediated cytotoxicity will occur. So eczema, this is the immunological way where the eczema or the dermatitis occurs. Eczema may be provoked in a non-allergic manner as well, as in irritant contact dermatitis, where the substance will either chemically damage the epidermal cells or sometimes maybe thermal damage, heat, etc. Then certain irritants provoke a chronic reaction in which an effect on epidermal cell turnover predominates, leading to lichenification. So when the stimulation is chronic, there will be more cell turnover and epidermal thickening, leading to lichenification. So there are some clinical pictures here. You can see on the screen on your left-hand side where there is a little bit of white skin in the background and the erythema and oozing lesion. So that is acute eczema. So there is blood vessel dilatation leading to redness, warmth, and oozing. But when it goes into subacute and chronic forms, it becomes dry and pigmented and lichenified. So then we will talk about atopic dermatitis. Atopic dermatitis is the main group of dermatitis where we have to handle. Atopic dermatitis occurs in up to 5% of the population. Now, atopy is a different entity. About 20% of the population, the developed countries, about 20% of the population are atopic individuals. So these atopic individuals, the atopic diatheses, are a group. So they are, common one is asthma, and then dermatitis, then allergic conjunctivitis, and allergic rhinitis. So you can see that these are the surfaces where the human is exposed to the external environment: skin, nose, eyes, and the respiratory epithelium. So there is hypersensitivity to certain substances that lead to these atopic diatheses or diseases. So it is much more common in early life. So in pediatric matrix, we see a lot of atopic dermatitis patients. And in atopic dermatitis, about 80% of them will have increased total IgE levels. So there are genetic factors which contributes to atopic dermatitis. It is complex with strong maternal influence. There is a 90% concordance in monozygotic twins. So if in monozygotic twins, if one is affected, 90% chance the other one is also affected, but only 20% in dizygotic twins. So there may be environmental factors as well where the dizygotic twins are exposed. If one parent has atopic disease, the risk for a child developing eczema is about 20 to 30%. So if both parents are affected, that increases up to 50%. So we will go through the pathogenesis of atopic dermatitis. So basically there is inflammation. So inflammation is manifesting clinically as pruritus and scratching. Then there will be growth of colonization of staph, especially staph in atopic individuals, because they have certain defects in their barrier. Now, when you do dermatology appointment, I usually discuss when you come on the first day the functions of skin. So probably you may have had lectures regarding this. So one of the main function of the skin is it is acting as a barrier for the to maintain the internal and external environment separately. So this barrier is not properly functioning in atopic dermatitis. One reason is they have less filaggrin. Filaggrin is a protein which keeps the keratin together. So when it is less, then there is some defect in the cytoskeleton, as well as they have a defect in the chemical substances found on the epidermis, that is the outermost layer. So these are inherited defects in the barrier. So then, so the connection between these, so these inherited defects will cause sustained barrier defect in the atopic dermatitis individual, and that will be contributed by the environmental triggers. So sometimes the changes in pH, lot of cleaning, etc., exposure to detergents, then very dry or low humid environment, etc. So on the left hand side, you can see both these inherited and environmental factors continue to maintain this barrier defect. So this barrier defect will lead to inflammation because the substances can enter into the skin, and the inflammation will further deteriorate barrier. So when there is damage to the epidermis, so it is both ways. You can see the arrow sign both ways, and it is predominantly Th2 group driven inflammation. In contrast, if you and remember, in psoriasis, it is Th1 and Th17. Here it is Th2 and interleukin-4 mediated inflammation. So this inflammation will cause pruritus, and pruritus will further cause damage to the barrier as well as aggravate the inflammation. So these arrows are going here and there as a circular manner. So you can see that interacts with each other and cause further damage in a vicious manner. So this in atopic dermatitis, Staph aureus colonization is much more. So they have more Staph aureus living on the skin without any causing any infection as such, but they will progress the inflammation and contribute to the high IgE levels. So when there is IgE levels, that again drives inflammation, pruritus, and scratching. So these are the basic, the cycle of pathogenesis interrelated in atopic dermatitis. So this is not common to all type of dermatitis. Some components are common to all types of dermatitis, but in atopic dermatitis, these are the features seen in the pathogenesis. For the diagnostic, it is a clinical diagnosis, atopic dermatitis, but we can use these criteria for diagnosis to give a diagnosis as atopic dermatitis. It must be an itchy skin condition. So atopic dermatitis is one of the most pruritic conditions. So we have several skin diseases which are very much pruritic. Atopic dermatitis is one of them. Especially in children, so they keep on scratching, and sometimes the child gets irritated and cries and wake up in the night, wake up the parents and ask them to scratch, and so the parents are up, the siblings are up. So this pruritus can be a disaster for the whole family sometimes. So that is in a small child, the parents will report of scratching. Sometimes in the neonates, they can't directly scratch, they can't locate exactly, but they will start rubbing against a cloth, or sometimes they will keep on moving their fingers on when they touch even the mother's skin. So there are 3 or more of the following. So history of skin creases involvement. So that is, skin creases are involved in atopic dermatitis, like folds of elbow, behind the knees, fronts of ankles, the neck, and around the eyes. A personal history of the other atopic diseases like asthma or hay fever, or atopic disease in a first degree relative, that is a family member, in children under 4 years of age. So up to 4 years, sometimes they may not have developed the other atopic diseases. History of generally dry skin in the last year, during the last year, long-term dry skin, and when examination, visible flexural eczema or eczema involving the cheeks, forehead, and extensor limbs in children. In the early part of the life, it involves the extensor areas and the cheeks. So onset under 2 years of age, that is, it is a disease of children, mainly atopic dermatitis. So onset under 2 years of age can be considered in an elderly person, but it is not used if the child is under 4 years of age. So this is the first area to enroll. In about 3 months of age, they get acute facial involvement. You can see the erythema scaling and bit of excoriation, so very much inflamed skin, mainly the cheeks and the face and or the neck. So that is how in the early part of life it presents. So gradually it goes into the flexural involvement. Here, back of the knees, there is a bit of crusting, erosions, and scaling, and the dryness is visible in the picture. And also in brown skin, again you can see this light color or hypopigmentation with bit of scaling, and erythema also is visible. On the abdomen, you can see tiny spots of hypopigmentation, that is the atopic dermatitis can involve the hair follicle. So we call it follicular accentuation. So that is also a feature for atopic dermatitis. In this picture, this is a close-up view, follicular lesions. So sometimes atopic dermatitis can have this manifestation as follicular eczema or follicular hyperkeratosis. Then in severe forms, atopic dermatitis can give rise to exfoliative dermatitis, where the body surface is about 90% involved. So in this child, you can see it is very much erythematous and sometimes excoriated and very much inflamed skin due to exfoliative dermatitis following atopic dermatitis. In adults also, atopic dermatitis can persist, rarely, not commonly. Rarely, sometimes atopic dermatitis can be late or adult onset as well. Then in atopic dermatitis, there are certain complications. Certain complications are there. There are so many actually in atopic dermatitis. They have growth retardation in severe atopic dermatitis and the drug side effect related problems, etc. And sometimes psychological issues, but these are the skin manifestations. You can see the impetiginization or impetigo occurring over the eczema lesions. So this is staph color. You can see the yellowish, golden yellowish color in the crust, as well as there are tiny pustules, if you can notice over the foot. There is another pustule. So this area it is crusted lesions. So these are impetiginized atopic dermatitis lesions. So that's a common thing. Now, in atopic dermatitis, they have staph colonization, plus they have higher chance of getting secondary infected with this staph. Then this is eczema herpeticum. Now, other than the bacteria, the viruses, herpes simplex virus can infect these lesions. So then again, they will present with an exacerbation, but sometimes they may have fever as well. When you look at the skin lesions, other than the inflammation, you can see tiny stellate-shaped, tiny vesicles or the broken vesicles. So you can notice them here. There is a broken vesicle and tiny, like punched out those stellate lesions are there on top of the dermatitis. So then we have to treat them. In impetiginization, we have to treat with antibiotics. And here, eczema herpeticum, we have to treat with acyclovir, in addition to treating the dermatitis. In atopic dermatitis, there are certain exacerbating factors. Now, so these are like the things which we have to talk with the patient and keep the patient educated. So infection, now you saw the pictures, infection and the super antigen effect. Now, this stuff can stimulate our immune system in somewhere in midway, rather than going through the antigen detection, presentation, T-cell stimulation. So they can directly stimulate the immune system via the toll-like receptors. So that is called superantigen effect. So staph always is a problem in atopic individuals. So that is why we want them to have a daily bath to wash off this excessive staph on the skin. Then the irritants, strong detergents, chemicals, and even woolen clothes can be irritant and exacerbate eczema. Sometimes it may be aggravated during the teething in young children, and severe anxiety or stress in any person can exacerbate the eczema. And the external allergenic stimulants like cat and dog fur, sometimes pollens, then house dust, actually, especially the house dust mite. So you get the mites living in the house dust, the human, the epidermal cells, etc., which is shed in the house. So these can aggravate the atopic eczema, and sometimes food allergens may be contributing. Then the complications are, we saw the Staph aureus infection, then viral infections, we saw the pictures, and also the molluscum. Molluscum contagiosum may be very extensive in atopic individuals. Then HSV, called Kaposi varicella eruption or eczema herpeticum. Conjunctival irritation, keratoconjunctivitis, and cataract. So this has the, the conjunctiva is part of the allergic conjunctivitis, so that they can get inflammation. And also, in addition, eyelid pruritus can give rise to frequent rubbing over the eyes. So these habits can, give rise to certain complications in the eye, including keratoconjunctivitis and cataract. Retarded growth in severe eczema, because it is an inflammatory condition, so the appetite will be poor, and it is a catabolic situation, so the energy loss is more, and also due to the myths in parents where the atopic dermatitis individuals should not be given proteins, etc. So there are so many factors for the growth retardation, including the effects of long-term steroid use. The prognosis, the majority of children with early onset atopic eczema will spontaneously improve and clear before the teenage years. 50% being clear by the age of 6. So most of them will be, by the teenage, they will be clear of the disease, but still they will have the dryness and the tendency for the irritant contact dermatitis. So few will get recurrences, and at least sometimes in the form of hand eczema. And if the onset is late in childhood or in adulthood, it follows a more chronic and relapsing course. So the management. So now there are different aspects of management. Now we talked about barrier defects, so barrier related. So we should try to reinstate the barrier function, at least to a certain extent. Then we have to control the inflammation. So both are interrelated, and reduce the pruritus, which drives the disease with the aggravating inflammation and damage to the epidermis. And management of acute flares like impetigo or the eczema herpeticum. Then nutrition-related issues and parental education and compliance. So atopic dermatitis is a family problem, not only one child's problem. Sometimes more time and money is spent on the atopic child, so the other children are neglected. So there are so many aspects if we talk in detail about management of atopic children. So basically the therapeutic ladder for atopic dermatitis is emollients. That is the moisturizers. So that is basic therapy which they have to apply just after bath within 3 minutes, as well as any time the skin is going to be dry. Then as a specific treatment, we can use topical corticosteroids. So in the damaged skin, we are directly applying the steroids to the site of the pathogenesis, so that will be effective. And we can add topical calcineurin inhibitors to minimize the steroid side effects like epidermal atrophy and depigmentation, etc. Then in severe cases, we can go for phototherapy. So phototherapy, I don't know whether you will get a lecture, but when you do the appointment, make it a point to see the phototherapy machine and how it is being done. Then systemic immunosuppressives can be used short term for severe flares, and if they need long-term immunosuppression, cyclosporine, azathioprine, mycophenolate mofetil, and methotrexate all can be used even from the small children. Sometimes we happen to use these immunosuppressives because disease is more devastating than the side effects of the drugs. So then at that point, we start these immunosuppressives even in children. So the adjunctive therapies would be wet traps. When there is a lot of oozing, we have to allow that serous discharge. So we apply sometimes condis. There is gauze soaked with condis wrapped on the skin that will sort of cool the skin and also act as an antiseptic. So this can be combined with topical corticosteroids on the lesion, and then we cover with the normal saline soaked gauze. Then condis can be used as not as a wrap or a compression. We just wash with condis or sodium hypochlorite. These are antiseptics, and then apply the steroid creams. So treatment of associated bacterial or viral fungal infections should be given if they are infected. Just for colonization, we don't use antibiotic systemic. Colonization should be handled with the local measures. Oral antihistamines for antipruritic and sedative effect. Actually, this is in this situation, histamine is not the only mediator of pruritus. So antihistamines may not completely control the pruritus, but still we use sometimes sedative antihistamines to keep the patient sedated, at least during the sleep. He will not be scratching. So bathing is an important aspect of management of atopic dermatitis, at least once a day. Not to use very hot water, and bathe for about 20 minutes. That is the ideal time they have found. Not very short, not very long, because when you have a long bath, that will wash off the natural lipid layer. And better to use a bathtub. I mean, the child is immersed in the water rather than a shower. So soaps make the skin alkaline, so that we have to use a soap substitute. So the usual, the commercial preparations will make the skin alkaline. But in a normal person, it will be back to normal by about 1 hour, but that doesn't occur in atopic individuals. And Equus cream can be used as the cheap and easily available preparation. Then cetrimide shampoo can be used to clean the scalp. There is antiseptic shampoo. And sometimes we ask the parents to add a bit of emollient to the bathing water so that it will remain as a thin layer. So these are the benefits of why now if you work in a dermatology unit, you will see for atopic individuals, we always have a daily bath. So what is the importance? So it hydrates, washes off the pathogenic bacteria, and washes off the serum, pus, sweat, etc., and reduces the inflammation and pruritus, and in turn the patient feels better, and appetite will improve, and the sleep will improve, and also if it is the patient is a child, the mother-child relationship will be improved with bathing by the mother. So I think you are feeling like this, sleeping, but still we have few topics to cover. So irritant contact dermatitis. So now we will switch over to the other forms of dermatitis or eczemas. Hope you can remember I mentioned that endogenous and exogenous eczema. So this contact dermatitis comes under exogenous eczemas. So irritant contact dermatitis, this is the cutaneous response to the physical or toxic effects of a wide range of environmental exposures. So irritant can be any agent, like something which can physically or chemically producing cellular damage if applied for sufficient time and sufficient concentration. A gross example will be sulfuric acid. If it is concentrated, that will burn the skin. So, or otherwise very low concentration, but if you keep on applying, again the same effect will happen. So, but in day-to-day life, these may be cement, maybe soap, maybe fertilizer, something like that. So here it is not necessary to have immunological memory or sensitization. And so it can occur at the first exposure, and it will occur in anybody who is being exposed to the particular concentration or the duration. So it is not limited to one, particular group of individuals. Contrast to the allergic contact dermatitis, where it is needed to have a high previous sensitization. So often occurs on the hands after repeated exposures to irritants such as detergent, soap, or bleach. It is common in housewives where they all the time keep on washing, cooking, etc. And cleaners, hairdressers, mechanics, and nurses, again due to frequent washing of hands and handling of medications and detergents, etc. So here you can see irritation after exposure to juice from mango trees. So sometimes they can be a common irritating substance. You can see the inflammation and epidermal cells are being damaged and crusted. Here again with severe inflammation and vesicles and epidermal sort of peeling. Then here, this is what happens in how to handle chemicals frequently. So sometimes they get concentrated in the finger webs. So the other areas they wash quickly, and so the water will take over the material. But in the finger, they remain for a longer time. So that gradually, after a couple of weeks, so they develop this inflammation in the finger webs. Sometimes it may spread to the other areas. Sometimes we call it housewife's hand. So allergic contact dermatitis, it's a delayed type 4 hypersensitivity reaction, T-cell mediated, with varying degrees of erythema, edema, and vesiculation result from cutaneous contact with a specific allergen. Should be a specific allergen which has been exposed before and where there is immunological memory. So it occurs only in those people who are susceptible, not in all, like in irritant contact dermatitis. So many substances can cause this type of reaction. So there are common allergens like nickel in jewelry and buckles, the wristwatch strap, etc. Then chromate in cement. Then latex in the gloves. Then perfumes in certain cosmetics and air fresheners. Sometimes plants, primula and composite, a group of plants. A good history is necessary to identify the allergic agent, and we have a thing called patch testing where we have certain common allergens in a certain concentration. We apply it to the skin and leave it for about 48 hours with a plaster and see whether the person is developing any reaction. So that is to confirm the allergic contact dermatitis. So these plants causing this contact dermatitis. Then this is called sometimes garlic dermatitis, where people who cook, these are the 3 fingers where they hold garlic or onion or maybe some other cooking material sometimes, then and keep on chopping with the other hand. So these 3 finger sign, or sometimes it can occur who pluck kirid the flower. So kirid is a the juice is a common allergen again. So similar picture can occur with this, the three fingertips. Then due to various exposure to cleaning material in this patient, you can see severe dermatitis. Sometimes various cosmetic applications can give rise to this type of allergic contact dermatitis. Sometimes the nail varnish, they use the cutex. So that can give rise to this type of reaction because they scratch their eyelids with the nails. So the nails are not, it is not directly connected with the immune system, but the skin over the eyelids are very fine areas. Here, sometimes nickel allergy, where they keep the keys in their pockets, so that developing the dermatitis over the touching areas. So asterotic eczema, we call it eczema crackle or winter eczema. In winter time, the humidity is low. So this low humidity will give rise to dry skin in a particular individual. So sometimes in elderly, sometimes due to certain drugs, sometimes due to certain diseases like leprosy, sometimes certain neuropathies can give rise to dry skin in certain areas of our body. So in that area, you develop this steatotic eczema or eczema crackle. So there will be cracking, which leads to barrier defect and stimulate the inflammation. Occurs in elderly people, lower legs and backs of the hands. So that will be worsened with frequent use of soaps, etc. So sometimes can be associated with hypothyroidism and also renal failure. So treatment is avoid soaps, regular use of emollients and bath oils, and topical steroid ointments. Here in this picture, you can see the cracks. So there are so many cracks. And around the cracks, you can see the inflammation occurring into eczema. Discoid eczema. Now it is coming under the endogenous eczemas. It is, but anyway, a descriptive term. Discoid is disc-like eczema. So this is a morphological variant of eczema. So this entity is a non-entity, but we don't know why it occurs like that. Characterized well-demarcated scaly patches, especially on the limbs. So sometimes confused with tinea or psoriasis, occurring in both atopic and anaatopic individuals. So there may be secondary infection. Now here you can see the disc-like lesion. So now you can see a little bit of border different to the center, so that may mislead thinking it is a tinea infection, but the central area also is eczematous and there is no papular border. So this is a patient with discoid eczema, so that is again managed like in other eczema. So in hand eczema, itchy vesicles or blisters on the palms and along the side of the fingers. So these are called pompholyx. Now in hands and also feet, the main difference in the skin is it has a very thick stratum corneum. So if you can remember, I showed you how the vesicle develops in the epidermis. So that there is a vesicle being developed under the subcorneum, the stratum corneum. And when the stratum corneum is thick, it can't burst out. So that will remain as a vesicle or blister. So it is equal to sago-like appearance over the hands and fingers and the sides of the hands and the fingers. So it is called then pompholyx. Diffuse erythematous scaling and hyperkeratosis will follow. And sometimes they start peeling and most marked at the fingertips. So hand eczema can be exogenous as well. Sometimes endogenous, sometimes exogenous. So hands are exposed to various substances. So contact irritants, contact allergens can give rise to either irritant contact dermatitis or allergic contact dermatitis. So due to different substances and also different stimuli like friction, mind trauma, cold, dry air, etc. Sometimes ingested allergens like some drugs, nickel containing food, chromium containing food can give rise to hand eczema. Sometimes infections can drive against hand eczema like bacterial or the wounds on the hands. And sometimes when you have infection in a distant place, there may be some inflammation going on in the hands or the fingers. So that is called id reaction. Or when it is due to dermatophyte infection in the, for example, between the toes, you get this reaction in the hand. So we call it dermatophytid reaction. So id reaction. So that is inflammatory reaction with secondary dissemination. So endogenous hand eczema can be idiopathic, like discoid eczema, hyperkeratoid palm eczema. Then there may be immunological or metabolic defect, example, atopic dermatitis. So atopic dermatitis may just manifest as hand dermatitis. So by the way, now in atopic, the barrier defect is there, so they are more prone to irritant contact dermatitis because the barrier is breached, the irritant substance can easily penetrate the barrier and induce damage to the cells. So psychosomatic stress aggravates the hand dermatitis, but may not be just the sole cause for that. Dishydrosis, increased sweating, aggravates the hand dermatitis. So this is an example. You can see the inflammation and bit of dryness. So seborrheic dermatitis is where you get dermatitis over the seborrheic area. So due to overgrowth of pittosporum ovale or malassezia furfur together with a strong cutaneous immune response. So when they are there in anybody, but in some individuals there is a increased response. So erythematous scaling along the side of the nose, eyebrows, in the scalp. So those are the seborrheic area where there is more sebaceous gland activity. So that is why it is called seborrheic dermatitis. May affect the skin over the sternum, axillae, and groins. Also sometimes even the pubic area as well. In here you can see, this is a white skinned person, you can see the erythema and the scaling, sometimes whitish scales over the typical seborrheic area. Now here actually it is a bit of a troublesome disease because it keeps on appearing. So we go for a suppressive rather than curative treatments, combination of mild steroid as well as a mild as well as an antifungal agent. So there are combinations with antifungals and steroids. So those are, here it is an indication to use them like miconazole and hydrocortisone. Not very potent steroids, keep that in mind. Never use potent steroids on the face. Then we can add topical tacrolimus ointment or pimecrolimus to support steroids. Antifungal shampoos can be used for the scalp, and emollients and soap substitute will help improve the symptoms in seborrheic dermatitis. Pityriasis alba is another common mild variant of eczema, which is much more common in children and children with atopic disease. In atopic disease, the skin is dry, and sometimes with sun exposure, these things are aggravated. Here it is ill-defined border is there, so you can sort of exactly delineate the area, unlike in pityriasis versicolor. And there will be fine scale, sometimes photoaggravation is described. So again, mild steroids and emollients will help. Then gravitational eczema. So as the word means, gravitation, so it depends on the gravity. So when the people have venous valve, the valve incompetence in the lower legs, the veins become engorged with blood. They can't pump the blood up when they are in erect position, so standing up. So then there is the effect of gravity. So that will lead to these red cells being extruded to the surrounding tissue. So this red cells leaking out from the vascular compartment will, over the time, will induce an inflammatory reaction. So that is called stasis eczema, venous eczema, or gravitational eczema. So while treating for the dermatitis, same time we have to address the venous stasis as well. Nodular prurigo is not an uncommon presentation. So this is assumed to be a chronic stimulation, probably due to insect bites. So when the mosquitoes or any other insects, ticks, etc., when they bite, they inject saliva into our skin, and sometimes they leave some mouth particles attached to the skin. So this can give rise to long-term irritation, immune stimulation. That will give rise to itching. That will be a vicious cycle. So, and will thicken the skin and give rise to a papule or a nodular lesion, which is very pruritic. So nodular prurigo. So we have to address this insect bites as well as treat with topical steroids, antihistamines, etc., and emollients, and over a longer time. So that is the end of my presentation. So if you have any questions, I think you can talk with me, I suppose. So then I will wind up. Right. Thank you.